Hello and welcome everyone to our special COVID-19 session number 26. This is a special series of sessions that we have dedicated to diagnostics in the pandemic. So a very good morning, good afternoon, and good evening, depending on your location. Excited to have you all from Cape to Cairo, from the eastmost part of the continent to the westmost part, and most importantly, from all corners of the world. It is always a pleasure having you here. Today's session 26 is about a very important subject, which is antigen rapid diagnostic tests. But today, we are actually unpacking the global launch of the COVID-19 antigen rapid test kits that were launched just about a week ago. These are fast, easy to deploy diagnostic methods that could actually become a game changer in quickly informing decisions about reopening economies and borders, which is something that is key of late. We all recall that on Monday, the 28th of September, just about last week, the Access to COVID-19 Tools Act Accelerator, as global health partners, announced huge plans to make available up to about 120 million affordable, importantly, high quality COVID-19 antigen rapid tests for low and middle income countries. These are actually tests that should be able to give us results in a very short time, 15 to 30 minutes, and can actually enable us to expand testing and particularly coverage where this has been limited for mostly molecular PCR, and it's actually where also PCR has been overwhelmed, as well as resulting in long turnaround times. So today's session, we are actually going back into this launch and seeing how this means for all of us. It will be a 1 hour long session made up of a panel discussion. And then in this panel discussion, we will explore the implications of this global effort with respect to how the coordinated implementation will happen. We'll touch issues of quality assurance, supply chain, distribution, finance, and most importantly, the issues of timelines. I invite you to enter your comments and questions into the chat box as we continue the session. And to help us explore this, we have a rich lineup of experts in the diagnostic arena, and we are honored at ASLM to have them make time available for us today. Ladies and gentlemen, allow me to introduce our panelists for today. Firstly, we have Dr. Yenu Kibede, who is the head of laboratory services at the Africa CDC for prevention and control. And we also have Dr. Lara Vojnov, the diagnostic advisor at WHO. We have Dr. Trevor Peter, who is a senior scientific director at the Clean Health Access Initiative. We also are glad to be graced by Ms. Smilka Delusini, program manager for HIV molecular diagnostics at cervical cancer at Unitaid. Also introducing Dr. Sergio Carmona, who is the chief access officer at the Foundation for Innovative Diagnostics. And we also have Aziz Jafarov, who is the manager for global sourcing health technologies at the Global Fund.
Today, I have good news. I'm pleased to announce that thanks to an agreement between WHO and partners here today and others, a substantial proportion of these rapid tests, 120 million, will be made available to low and middle income countries. These tests provide reliable results in approximately 15 to 30 minutes, rather than hours or days at a lower price with less sophisticated equipment. This will enable the expansion of testing, particularly in hard-to-reach areas that do not have lab facilities or enough trained health workers to carry out PCR tests.
So this is one of the key main subjects that we are going to be talking about, as we have heard from the Director General of the WHO announcing the launch of this test. So I think the interpreter is now on, so that I think those who are able to, who would want to switch on to the French language can be able to do so. Thank you, Beatrice, for being able to fix the problem. So as we move into today's discussion, I would like to call upon Dr. Yenyu Kibede from the Africa CDC and ask Dr. Yenyu, tell us about this partnership and what does this global partnership mean for the African continent, and particularly for the partnership to accelerate COVID-19 testing in the continent. Dr. Yenyu.
Thank you. Thank you, Anavi. Thank you, everyone, for joining this call. First of all, I would like to recognize and thank distinguished panelists, my colleagues lined up to talk today in this important session. Their support to Africa CDC and the continent has been really important for our COVID response in the continent. So early in the phase of this COVID-19 pandemic in the African continent, as you know, African Union Commission through the African CDC convened ministries of health where continental strategies to be led by the Africa Task Force for Coronavirus, which we call it AFCOR, was endorsed. And one of these strategies was to scale up testing for SARS-CoV-2, especially at the early phase of the epidemic, because testing is relevant at early phase of the pandemic. And in line with that, Partnership to Accelerate COVID Testing, PACT, was launched in April 2020 to mobilize resources and build strong partnerships to conduct more than 10 million tests between 6 to 4 months. And during that time, the continent was only at less than 300,000 tests. And some of the countries even don't have testing capacity in country. So as I speak now today, the continent has done more than 16 million tests, which means that 1.2% of the African population has been tested for SARS-CoV-2. However, this testing level is still low for a continent of 1.3 billion people. And because of that, this partnership and the launching of this initiative to avail rapid and quality diagnostic tests for middle and low-income countries, mostly which are the member states in Africa, will be an important intervention to continue the scale-up of COVID testing in member states, especially in those countries where PCR testing capacity is low. As you know, one drawback of this antigen test is lower sensitivity as compared to PCR testing. However, frequency of testing and turnaround time is much more important as compared to sensitivity of a test. So this partnership, which involves key global actors in the field of diagnostics, such as FIND, UNITAID, WHO, ASLM, Melinda and Gates Foundation, Global Fund, CHAI, and others that I have not mentioned their names, is a very critical step for continued supply of test kits to the African continent and to provide technical support for an effective and successful rollout of antigen tests for SARS-CoV-2. Africa CDC, as a member of this partnership, we would like to thank all these involved partners in this, and we express our commitment to move this activity forward, to prepare the continent to use the antigen test. So there is an attached sense of urgency to move this activity quickly, because scaling up of testing today and 3 months later, for example, is quite different in terms of the impact on the control of the pandemic. Therefore, my request today will be all of these important partners in this initiative to move quickly, so that we can start introducing antigen tests to the continent as quickly as possible. Because, you know, still there is a window of hope in the continent, because most countries in Africa have reported less than 100,000 cases, which means that expansion of the testing, isolation of identification of cases, isolation and quarantine of contacts will be a key intervention. And we are still at that early stage where we can still beat this pandemic. So after saying that, I would like to thank ASLM for organizing such important session, and also all the panelists and partners who are working with Africa CDC to really to support the continent. And because of my my commitment, I'm joining another call. I would like to apologize that I will not continue in the panel until the last. But we will be happy as Africa CDC to address if there are any questions. But we really are hopeful that more test kits in the next couple of weeks, not even months, couple of weeks, more and more test kits will come to Africa and benefit the continent. Thank you, Anafi. Thank you everyone for listening. I'm really honored to convey this message on behalf of Africa CDC. Thank you.
Thank you, Yenu, for those remarks and opening our discussion moving forward. As we continue to really explore this, we are all excited that WHO recently, listed on the WHO emergency list the first 2 antigen SARS-CoV-2 tests in the name about PanBio and SD standard rapid antigen tests. I want to ask Dr. Vojnov from the WHO, how useful are these antigen tests? Just this morning, I received a question exactly like that in my mailbox. How useful are these antigen tests in making sure that more people will actually receive the required testing? And what efforts are you making to make sure that we expand testing to control the pandemic?
Great. Thank you for this, Anafi. Hopefully you can hear me okay. So I just first want to thank ASLM for allowing us and bringing us into this conversation today. A very important one, we think, and very timely, in fact. So from WHO's standpoint, we certainly see antigen-based rapid tests as playing a significant role in supporting and guiding patient management, as well as in public health decision-making and surveillance. Of course, I think you've all seen, and we had a session on this a few weeks ago around the guidance that came out on September 11th, touching on some of the key important pieces around responding to outbreaks, using these technologies to respond to outbreaks, around outbreak investigations, understanding the trends and targeting perhaps healthcare workers and others at high risk, and using it as an early detection and isolation tool. Of course, there's still a lot that we still need to learn in terms of the performance standards of these products. We have published now, just a few days ago, the target product profiles for these, as well as a few other products that we're trying to better understand to support countries. And of course, hopefully through some of these technical evaluations, through compiling those together with in partnership with the Cochrane team, doing those systematic reviews, we can better understand that performance to really speak to how widely these could potentially be used. But we do see the utility in being able to decrease delays and potentially expand testing. As Yenu touched on, we have seen some challenges in some of our settings to expand their networks and expand testing, given some of the delays in the molecular testing space. That said, I think we do want to appreciate the amount of testing that has happened, as Yenu has mentioned, in Africa, but around the globe. As quickly as February 2nd, the first tests were actually being shipped and delivered, including to some of the countries in Africa. And since then, within the diagnostics consortium, we've actually seen 34 million tests that have been procured and nearly 20 million tests that have been that are in transit currently or being delivered. Now, the emergency use list, like you said, is a really important tool that we've been utilizing within the WHO to support procurement that's being made through the supply portal as well as to partners. This came about relatively quickly towards the end of February, and within 5 weeks, they actually had put the first products on the emergency use list. At this point now, there are 20 molecular tests that are on that, and like you said, there are 2 antigen-based RDTs and a number of those that are currently in review and assessment. We see the role of the pre-qualification team and the emergency use list team as a very important component to really support countries, support ourselves in the procurement and others to ensure that high quality products are available, as well as in a key piece, supporting on post-market surveillance and being able to manage and monitor that as the utility, as they're expanded and procured and delivered to countries, particularly for products. And it's a little bit similar to perhaps how we were operating early in the HIV testing days as we started to deliver rapid antigen tests, the rapid diagnostic tests within that space, and really wanting to ensure the best quality for patients, but also ensuring that we're able to identify them quickly and then manage them and transmission onward from that point on. So we're trying to take a number of the lessons learned from those practices and really put them forward to better support countries. Thanks, Nafi.
Thanks a lot, Lara. And indeed, I think this could be a game changer, as Joseph Adoyo has just said in the chat, that this is a valuable game changer in the fight against COVID-19. Please keep the questions coming. We'll take them as soon as we finish with the panel discussion. Lara, you mentioned that there are quite a lot of tests that have been done, molecular tests. And I think Yenu also mentioned that in his opening remarks. And just looking at the statistics, and one of the things that we have been worried about, particularly on the African continent, is that gap between the testing rates. I think they have been reported to be up over 200, specifically around 292 tests per day per 100,000 in the developed world. And it goes down like that on a sliding scale to just around 40 per day per 100,000 in low income countries. And some of this has been attributed to maybe sort of, I will put in quotes, the inequitable distribution of supplies. And what we also had is this deal, this partnership sort of guarantees volumes from suppliers. I want to come back to either you or Dr. Yenu in terms of what has been put in place to ensure that the African continent and other low and middle income countries are not left out, just like the way we might have felt for PCR tests.
Great. Happy to touch on that. So within the diagnostic consortium, and this is through WHO, Global Fund, UNICEF, UNDP, PAHO, GDF, and a number of other key players have been trying, first using molecular tests as a base to secure and provide diagnostic tests in an equitable way. Of course, this obviously is driven and hopeful to be able to support low middle income countries. We've now included 7 small and developing states that have restricted access due to their market availability. And the idea is to try to support those countries that maybe don't have the market interest from suppliers that might be seen through high income settings at this point. So we've been able to secure, like you said, some relatively small volumes for the molecular side, but I think this agreement, and others will speak to this, around the now availability of these products for low middle income countries. And similarly, we want to leverage a number of the lessons learned from the molecular side in terms of the frameworks of allocation, of an equitable allocation, and a coordinated procurement mechanism to try and ensure that low middle income countries are able to access these products with the need that they have at this point. And of course, like you said, we do see this as potentially being a game changer. I think we also want to see some additional evidence to be able to notify our guidance a little bit further. Of course, the current evidence that exists is primarily focused on sensitivity and specificity, and I think Sergio will speak to that a little bit more. But ideally, we're hopeful that additional guidance, additional evidence will be able to come out for us to be able to refine that guidance in the future as well. And we have some considerations here around potential implementation studies and pilots where we're working with a number of countries, including those within Africa, to try and support us to do so.
Thanks again, Lara, for that. I don't know whether Yenu is still there or he has left. Okay, that's fine. You mentioned the performance, and I would like to call upon Dr. Sergio Carmona. We are also delighted to have you on the call today. As a co-convener of the Accelerator, this is probably the first major announcement on the availability of high-performing antigen tests, and it is a result of major international cooperation that we might have seen. How is the Accelerator supporting the antigen rollout related to these COVID-19 innovations, given that we have had some concerns around maybe performance coming through? Can you maybe shed light on how this has been planned?
Great. Well, first of all, thank you again for inviting FINE to this forum and explain a little bit what ACT has been doing. And yes, the culmination of the announcement just over a week ago of 120 million worth of a package. But maybe I should start by saying that the ACT Accelerator is a framework of collaboration that includes many of those of you who are present today and your organizations. It was launched in April this year through an announcement by the Director General, and it aims to accelerate the access, equitable access to tools to combat and ultimately, if you want to call it, defeat COVID-19. There are four main pillars, so it's diagnostics, treatment, vaccine, and the fourth one, which is equally important, is health system strengthening. We are in the first pillar, which ultimately is the one that we need first, and it's focusing on the development and making equitable access to testing. As Lara pointed out already, we started with what was available, which was a molecular test, high throughput, and then manual PCRs, with a fairly complicated algorithm to execute an equitable distribution of those tests. It was not easy, much was learned, and a lot of pressure, and against a very competitive market that was very much a seller's market, shall we say, so left LMICs behind. We hope to have learned from that experience and ensure that with the announcement made just over a week ago, that we prevent that, right? In essence, the package, it will make available 120 million affordable, high quality COVID-19 rapid tests. These are predominantly from 2 suppliers. And as you already mentioned, it will make available a result within 15 to 30 minutes, unlike molecular, which is still the preferred gold standard if you want, but where there are gaps, either because of lack of access to molecular test or because results will take too long, this will play a key role in addressing in containing the pandemic in the continent. In terms of performance, is that yes?
Yes, I was going to follow up in terms of Yeah, usually that's where
the key question, right?
Right?
So in terms of performance, we know that, and again, invite you all to go to the FIND website where details of all of this available. It's in terms of sensitivity, perhaps is not reaching those levels of attained by PCR. But I think we're seeing more and more evidence that antigenicity equates also to infectivity. So it's perhaps a good clinical indication that these individuals are shedding viruses that can then infect others. The use cases are already well defined in the, I think Lara pointed out in the WHO guidance on where best to use them, right? And I know in the continent and in discussions with Africa CDC, ASLM, and many of you yesterday, we're also exploring what does Africa need? How can Africa make good use of these antigens, AG-RDTs? Because perhaps the use cases may be slightly different. And we need to support that with good evidence.
Thanks a lot.
I answered most of your questions.
Yes, so there's still quite some more in the chat, so I think we'll come back to them as well.
Okay.
Yes, I want to also move on a little bit and go over to Smilka from Unitaid. Unitaid's backbone, I think, of its strategy, and possibly I could say the DNA of Unitaid is usually embraced in catalyzing innovations. And we see it also, Unitaid is involved in this coming through. There's an element of cost here. It's being said it's going to cost $5 US. Wow, this is relatively cheap, but people can say cheap is relative, but it's a good start. What opportunities do you see with antigen tests, and what are the priorities that need to be taken to ensure effective use of this new diagnostic, especially in the middle of the pandemic? Smilka.
Thanks so much, Hanafi. And thank you also for being always at the forefront when it comes to information sharing in the diagnostic space for the continent. It's been really so important to kick off this partnership. We've been waiting for antigen RDT since quite a long time. We knew that PCR can go as far as it went, especially in terms of decentralization. So for us, it was important to wait for the innovation in antigen RDTs and actually create the strategies to deploy them most effectively. And I will come back to the price because I agree with you. The costs are relevant and relative as well. And definitely we can go much lower than $5. But I wanted to just focus on 2 points here. Probably for the first time in many years, but definitely in the latest public health issues that we've been seeing across the globe, this is the first time that we actually have technologies that are coming on the market be equally available at the same time and required across both high-income countries and low and middle-income countries. And this is very important because we are seeing, normally we would have technologies that were already tested and understood in terms of their performance, use cases, the best way to deploy them, because they were actually used somewhere else and then brought to low and middle income countries. But in this case, and with the partnership that we are also deploying together with national governments of Africa, which is very important point to raise, we will be generating evidence that will actually benefit globally to both high-income countries and low and middle-income countries. And so the pressure on one hand is there that we are not doing this only, and especially, of course, it is the biggest driver is the public health and economic case and impact that we want to make. But whatever we do and learn from the experience of rolling out these tests on how best to roll them out, whether we can replicate some of the learnings from HIV or malaria space into this, especially on decentralization, on self-testing, if we manage to improve sample types that are used with these tests. All of that will actually go back to WHO and help them improve their guidance that is currently not fully specific in terms of, I saw in the chat some people were asking about precise algorithms and how to deploy these tests. So these are learnings that we're hoping that countries like Kenya or Malawi or Nigeria or Senegal or South Africa, all the countries across the continent that will be starting and pioneering these tests will actually be contributing back to WHO as a guidance. So in that sense, the priorities across the next month is really that technology and manufacturers need to follow this. They need to follow it with improving their technologies, first and foremost in terms of performance, but also more simple sample types that will be used. And then you brought to the point of $5. And we are of the belief that these tests can go as low as $2. And that's something that we would want and are determined to work on together with the partners. But also on the other hand, the countries as well do have a huge role to play, as I explained, especially on securing fast registration, especially of the tests that have proven the performance, that have received the EUL listing from WHO. And then it is also about the funding. We do have 120 million volume commitment, and I'm glad that Aziz is coming up to me so that he can also speak to this. But 120 million that are yet need also the funding commitment behind them in order to be available in the countries. I will stop here and re-emphasizing again that learnings from Africa are going to be used globally in equally in high-income countries as well as other low and middle-income countries. Thank you so much.
Thank you, Sumika, for that insight. Yeah, you may in this deal, there are quite a number of key themes that are coming through: the issues of innovation, innovative tests, volume guarantees. You know, people have asked around sensitivities and how this is going to happen. I want to move over to Trevor and ask, Chai is at the forefront of many of these implementation activities. How are we seeing this happening? How is the rollout going to be happening? How many countries are going to be starting? What are the potential barriers? I think Sumika mentioned a few of them. And what have we learned so far that we could quickly use and move forward in terms of deploying these tests?
Thanks, Sanafi. So I'd like to start by echoing what Dr. Yeno Kabere from Africa CDC said at the outset of this panel. Given where we stand with this epidemic, it is important that we move quickly. If we look at past experience with other pandemics, looking at HIV and malaria, the deployment of new rapid tests has taken more than 5, sometimes 10 years to scale. We unfortunately do not have the luxury of time today. And so we need to take what we as a health community have learned from these past pandemics and apply them quickly to addressing COVID-19. And so speed is important, and a much faster pace than say 5 to 10 years for deployment is important today in order to stop the spread of the disease and to save lives. Some of the key steps that we think are important to address include sort of regulatory steps, because often long registrations and long evaluations can significantly slow down the introduction of new technologies. And this is particularly important when WHO has assessed technologies and provided an emergency use listing. And we certainly have 2 tests already today that have gone through that process and I think are ready to use. In addition, the FIND has done a number of evaluations and continues to do evaluations on tests. And I think we as a community and across countries can look to that and rely on WHO and FIND's evaluations to make decisions around the use of tests. It's also important to ensure that the right testing strategies are identified and used, and that funding is secured for deployment. We know that testing is often not adequately funded. And so it's important to look to donors and to government coffers to see how testing at the right scale can be funded and paid for. And lastly, it's important to conduct training and to ensure quality assurance. I want to talk a little bit about testing strategies briefly. It's important to determine the most optimal places to deploy antigen tests so they have the greatest impact. So we have to look closely at use cases. We have to consider testing within frontline workers in hospitals, in the community, at borders and other settings, and figure out where can tests be most effectively deployed. If we look at the recent WHO guidance, provided an antigen test has high performance, high sensitivity, high specificity, it can be used in a wide variety of use cases. And that's something that we need to look at carefully and look towards identifying and selecting high performing tests. High sensitivity, high specificity is very important in this context. It'll also be important as these tests get implemented, and I want to echo something that Smoker said just now, that we generate evidence, that we look at the performance of the tests in different use cases, what the testing yield is, how many positives are identified, what error rates occur, and so on, and use that information to inform future scale-up so that we can implement new antigen tests in a way that is effective for pandemic control. I want to make two other quick points. The first is that we also, as we move to rapid antigen tests, we're moving outside of the laboratory. And when we move outside of the laboratory, testing can become invisible. It can go offline. But we know that test results have to be captured, have to be communicated, used by health authorities for pandemic control. And so we need to look carefully at how we can deploy either paper-based or preferably electronic data collection and transmission systems so that as rapid tests are being conducted, that data is available in real time and can be used by health authorities for epidemic control. And lastly, I want to highlight a point also that Smoker raised, which is around sample collection. And we know that nasopharyngeal sample collection has been the standard to date. It is, however, a collection method that requires special skills and is biohazardous, and potentially could be a barrier to the widespread deployment of rapid tests, which in contrast are very simple to use. We know that the rapid antigen tests that are becoming available, those that are the two tests that are currently available through this global initiative, the Abbott Pan Bio and the ST Biosense Standard Q. Both of these tests will soon have a nasal collection, so sort of nostril-based collection method, which is much simpler. And early evidence suggests that testing using these type samples are actually just as sensitive as using a nasopharyngeal sample. So new evidence will grow in the coming weeks and months, and these tests will soon have a nasal collection option. I think that's going to be very important to enable widespread deployment. So I'll stop there, but these are some of the barriers that we see to adoption. I just want to emphasize the importance of moving quickly. I would lastly add that in terms of what we see in terms of countries adopting antigen testing, many countries are moving quickly. We know of up to sort of 15 to 20 countries that are really starting to evaluate and register antigen tests and starting early pilots to deploy them. So there is certainly a lot of momentum in this space, and so we look forward to further scale up across additional countries.
Certainly, thanks, Trevor. A lot of lessons learned from previous experiences that we need to make sure that we leverage on. You mentioned, I think, interesting statements that I picked today. We cannot afford to relax. Speed is important, but quality assurance at the same time needs to be taken care of. Once we're talking about speed and being important in this rollout, an interesting question always comes around procurement, which is usually sometimes a bottleneck. And I would like to call upon colleagues from the Global Fund. And we are excited that the Global Fund is also allocated about $50 million to initiate this rollout. I'd like to call upon Aziz to tell us about what is the process of initiating these procurements with suppliers. You know, how do countries leverage the global funding mechanisms and other sources of procurement? Basically, how is it going to be happening? Aziz.
Thanks so much, Anafi, for the introduction and also for the opportunity to be part of this forum and to discuss a bit the procurement side, which is quite, operationally important, and then a vehicle basically to make to provide access to the products to the countries. As you rightly mentioned, the Global Fund is actually from the beginning has been quite as one of the main public health funding institutions, quite engaged in the space of response to the challenge of the pandemic. And initially we have the Global Fund initiated basically two major basically approaches. One was just for the sake of speed to providing the opportunity to the countries with existing grants to use some of the flexibilities, up to 10% of the grants, to basically bring any, to use for any activities that would help countries to better respond to the challenge. And later then there was also a mechanism called the COVID-19 response mechanism, which was to enable countries to apply for additional funding. So overall it was around $1 billion US. And initially, of course, the focus was on many items, PPM, and also then how to make sure that the countries do not lose the speed of the program implementations for HIV, TB, malaria. But at the same time, there was a huge focus, how can we make sure that we do provide the tests, the PPE, and other vital products to the countries to help them with the response. So as Lara mentioned at the beginning of this forum, we do work closely with WHO and then WHO consortium members to jointly collaborate and coordinate all the efforts. And initial focus has been on coordinating procurement around mostly molecular tests, PCR-based testing, which has been quite successful in terms of million tests being delivered to so many countries by now. But now, as we have now new tools at hand, which is the focus of this discussion, of course, we would like to make sure that the countries get access to those products quickly, and then we can deliver those products to the country on time. Luckily for the space, there are products being approved, at least now with WHO, and there are 3 products, and there are more coming. And then there's a bit of sense of better supply availability compared to the PCR test, let's say, for the low and middle income countries for the antigen rapid test, which is a very good news, in addition to having a better pricing than for PCR. So, so we want to, just to keep it very practical for the Global Fund, the countries can leverage that 50 million indicated at the beginning through C19RM and flexibility of the funding. So this is being available, and countries can use the same platforms they use now for HIV, malaria, TB procurement. So through, for example, Global Fund pool procurement mechanism using, for example, the wambo.org or the transaction management platform. So we don't want to create something new, but we would like to use the vehicles we are using today, which are functional, which are quite efficient. So with that, within the Global Fund, of course, we have done a lot of communication, and also for the colleagues interested to know more and more details, there is a designated website for the COVID at the Global Fund website, which provides a lot of instructions, a lot of information about how to access this funding and how to place your orders, and then what are the lead times, and etc. So that is basically the approach we are building. We are building basically on what we have had so far for PCR and other technologies to quickly deliver to the countries. And of course, we will be using our procurement service agencies, which provide basically end-to-end service, meaning that they can get the products from the suppliers and deliver all the way to the country level and help with the distributions of those products. And in addition to this one, again, in the framework of WHO consortium, we have a very good collaboration. All the key partners we have are at the table. We coordinate and collaborate together to ensure that we do not lose sight on how the procurement is going and what are the allocations by countries and what are the deliveries we are doing today. And so that basically means that the other procurement channels but Global Fund are also available for the countries for procurement activities. For example, for PCR tests, they would channels like UNICEF, UNDP, for example, GDF Stop TB Partnership, and in also PAHO region WHO office was quite active, and etc. There are many partners which were willing to use their procurement mechanisms to deliver these tests. So for the antigen tests, all these procurement mechanisms are now open. So the other funding sources that countries may have through World Bank or other developing organizations, it's also something the countries can use and choose the best procurement channels for them to place orders and get these products to the countries. So that's basically in brief, and I would really encourage colleagues interested to know more to go to the Global Fund website. There's a lot of information published on how to get access to the funding and also information on the procurement mechanism. Over to you, Anafi.
Thanks a lot, Aziz. We appreciate that. Indeed, there is a lot, I think, in terms of this process. Probably we may need to organize a certain platform specifically for that as well. We do have quite a number of questions that are in the chat that we would want to tackle. But as we try to transition, I just wanted to play for you, hopefully it plays well here, this right. So that just summarizes this global partnership that has come through. So as we transition into the questions from the chat, we pick out that there are quite a lot of questions on performance. But before we go to that, there are some specific questions like, I think this could go to Trevor and Smilka. How many countries are being covered as we start? And what about sustainability as we move forward beyond the 120,000 tests? So Trevor, maybe you could check how many countries.
Right. So within Africa, of course, there are 55 member states that need to ideally would be introducing antigen tests and scheduling them. We know that obviously practically in the coming few weeks, part of the introduction plans will be dependent on support from donors and other partners, and that's likely to be in a phased manner. With probably, we expect maybe up to 20 countries initially getting some donations as to what we've seen so far, maybe 20 to 25 countries, so that's almost half of the continent. And that is from what a tally that has been done by the Africa CDC together with some of its partners. There's a visibility of up to 20 to 25 countries receiving some support. We expect that within the coming few weeks, that number will grow. And potentially up to the entire continent receiving antigen tests, maybe by as soon as early November.
Thank you, Trevor. There were questions around sustainability. Smika, do you want to pick that up?
So on the sustainability part, I think Aziz also discussed, and to the extent that some of the funding will be coming from larger funders. We are talking about at least the initial support for the first 3-4 months that would include And we're talking about registration support, figuring out testing algorithms, and really trying out the approaches that would work across different corners of the continent, and recognizing different decentralization methods, approaches, and use cases that countries might be adopting. Sustainability-wise, we are really targeting 3 areas. One is, of course, securing additional funding, and I think this is where we have seen also within the diagnostic consortium that is led by the WHO, that we have donors and the major procurers sitting around the table and aligning also around the funding needs as much as the volume needs. We have seen in the PCR space that even for some products, even though they were available, they were not taken up, and it was not the funding that was the determinant, but more the use of a specific product. So we will have to move and adjust as we see these products behaving in the field, so to say. The second one, the sustainability point for us definitely is the price reduction. At the and we have addressed this earlier, but definitely at the $5 point, this is not going to be a sustainable, at least at the volumes that we are required to cover the needs. And then we also need to start adjusting the forecasting and really understanding what are the needs and what is the demand. We cannot know that yet until with the certainty that we can in a couple of months when we understand use cases better. And the third pillar that we are working on, especially under ACTA, is to broaden the number of well-performing candidates for procurement. Today we have 2, but we hope we will have many more, and especially that will bring the price down and probably expand the use case options as the performance improves and also sample types improve.
Yeah, indeed. Thanks a lot, Smilka. I think moving on, between Sergio and Lara, there are quite a number of questions, so I'll try to lump them. I think a number of them around the algorithm. Do we have a diagnostic algorithm that can be shared? And then I think it moves on in terms of being used in remote areas, quality assurance coming through. And then interestingly from Asfau Gatachu, who says, Dr. Lara, what do you say about the duration of quarantine requirements following exposure? and he or she goes on to talk about the challenges at the health facility. Can we think of removing or shortening this in case of negative RDTs? I think it's all going around performance and algorithms. So maybe let's start with Sergio around algorithms, then maybe Lara, you can.
Lara can answer the issue on quarantine and how long will that last, right? I also want to hear her answer on that. Is it 2 days, 10 days, or 14 days? So in terms of, there's lots of questions on the chat. And the guidance that came out a few weeks ago from WHO was in many ways perhaps conservative, because there's also there's lack of evidence, right? And we acknowledge that. Evidence comes in many forms and of different quality and in different settings, and RDTs, because they're perhaps more accessible than PCR, are being used in fairly challenging scenarios, right? Where low prevalence whether it's COVID and antigen RDT, influenza, or any test would be stretched, right? At low prevalence, we're going to start to see false positives. And what we do know, and at the same time, we're learning every day the clinical course of the virus, and that also informs how these diagnostic tools help. We mustn't forget that there's a arsenal of tools. This PCR is still here. Antibody RDTs and serology do still play a role. And we're learning how the viral load, if you want, an antigenicity starts to increase even a few days before we observe symptoms, all the way to about 5 to 7 days, and in some cases up to 10. Now, and then we look at the data in terms of performance. We need to see where are these tests being used, right? I just want to caveat this. The two Abbott and SD biosensor are currently professional use only. I see in the chat there's lots of over-the-counter stuff. So just to make sure we're talking about antigen RDTs that currently are for professional use only, and most of them are caveated around symptomatic. Stretching the use case, for example, for border crossings and allowing in settings where there's low prevalence, is going to test the performance to the limit of these RDTs regardless, right? I've put on the chat there, but it looks like others are sharing details of performance, etc., quite a lot. I want to emphasize one thing. PCR, whether we like it or not, is not accessing all those exposed in Africa. There's still a major gap. We understand that PCR is indeed the best. My background is in molecular diagnostic. We all know that that's the best. However, this is an issue of providing accessible, timely results in settings where you may not have reached the service required. So maybe leave it at that. And Lara, I want to hear your answers on more tricky questions.
Lara, over to you.
All right, and I know we're running a little bit short on time. I think the piece on the algorithm component is an interesting one. We do have a little bit of suggestion in the current guidance from September 11th around that. But I think Sergio really touches on a number of the key points around the performance that we really still need to better understand. Because I believe another one of the questions is around points of entry and really thinking through potentially if these products do have lower sensitivities and specificities, we need to reflect that in the positive and negative predictive values. If the prevalence rates in certain settings are lower than hoped or lower than I suppose we need to have good performance to use these products there. And I think that's where a number of the studies that are going to be taking place, I know Unite, CHI, FIND, and others are looking to do so. Hopefully ministries of health are also going to support in terms of generating some of that evidence that can hopefully refine, not just on the performance side, but in general, some of the evidence to really identify and help us think through where we can start using these products beyond what we are currently recommending. And it's just really a gap in evidence at this point. I think on the quarantine piece, I would just refer to our already existing guidance to take a look at that and follow those closely. Back to you, Nafi.
Thanks a lot, Lara. And there are a lot of questions. We are almost at the hour and we want to respect, I think, people's time. So I'll try to take about 2 more questions. And one interesting one is coming from Chishamiso, who says probably the biggest question, that the big is in capital letters, is if we can use antigen rapid tests as diagnostic tests or merely for screening. Again, in testing space would be conclusive diagnostic, enabling reduction in testing volumes on the conventional RT-PCR. Interesting insights coming through there. And I think what also came through, I saw one comment which was around domestic funding. Is there domestic funding for antigen RDT? I saw quite a lot of comments in the chat where people have talked about countries having already evaluated some of these test kits. So interesting to know if there could be domestic funding. We may not be able to get answers from the chat, but maybe from one of the panelists, if you have any insights of what is happening.
Nafi, I suppose I can jump in a little bit. I think in terms of domestic funding, if that exists, and countries want to use that, absolutely, there should be no barrier to doing so. I think within the WHO, as well as the Diagnostics Consortium, we're also trying to understand those countries that may be struggling with funding in order to try and procure some of these products. And so we've reached out to our regions to try to better understand this, so that way, whether it's WHO or others, we can try to support countries to ensure that there's some funding that exists. Perhaps, you know, whether or not it's going to fully meet all of their needs is another question, but I think we need to really hopefully work together to try to ensure countries can have access to these products that they need.
Thanks a lot, Lara, for that. I know we are at the top of the hour, so just quickly in a few seconds, let me just give Aziz 30 seconds to just give a few seconds of closing remarks.
I think the key thing is what people need to understand is these products are available now, and then the organizations or the countries can use multiple channels to source those products. It can be through Global Fund and through other partners present in the country, such as, again, UN agencies, for example. And again, then the next point is all organizations are using their existing functional procurement channels, which are quite good, because that means quick delivery to the countries. And then also the other element, of course, it's good to keep an eye on the dynamics around the pricing. As with the more supplies coming to the board, we expect the prices to go further down. So I think these are some of the key points. And I think also, please use the websites to raise any other questions and send it to the organizations, and we will be providing the responses on those too. Over.
Thank you, Aziz. Sergio, just around 15, 20 seconds.
I would say, just to assure you, we find continues to push the agenda on the independence, generation of independence evidence. We're working closely with CHAI, Africa CDC, WHO, also in generating evidence around some of the use cases that are pointed out here, as well as improving access by ensuring that nasal and other source of samples can be improve access to diagnostics.
Thank you, Sergio. Trevor.
Thanks, Hanafi. I think, and thanks again for this session. I think it's been a very good discussion. From the CHAI perspective, we do everything that we can to try to secure early donations of rapid tests for countries so that some of their programs can kickstart. We know that there's obviously long-term government funding and broader global health and other funding that will come in to play as the months move on. But we feel that the next few weeks will be very important in terms of providing early donations to countries so that they can kick off their testing programs. Thank you.
All right, thanks, Trevor. Smilka.
Hanafi, just to be very short and to say that definitely the next 2-3 months as we deploy these tests and as we start generating the evidence will be critical to inform the way we are going about it. So that operational research agenda, but also just documenting the experiences and debunking some of the misconceptions maybe, but also fears that are founded in the different performance of tests, as well as the QA setup that needs to be around them, are going to be very important to address. So we are thinking about that and also working with partners in that space. Thanks.
Thank you, Smilka. Lastly, Lara, just a few seconds.
Great, thank you, Hanafi. And I just want to thank everyone who's joined the call today, ASLM for hosting this, and the partners who have shared the panel with me. I think this is a really impressive effort of collaboration and solidarity to get to this point. And hopefully we can see these tools being put together with the tools that already exist within the diagnostic space, but also combined across the board in terms of the service delivery and other commodities that are needed to try to really support countries to move forward to curb this epidemic. So I just want to thank everyone very much for that great work over the last few months. I know that there have been times when it's been a bumpy road, but I think we've really gotten to a really nice space in terms of being able to deliver this package, and hopefully we'll be able to do more good work over the coming months.
Thank you very much, Lara. What's left for me is to thank all the panelists for making time to share with us all the details around this global effort. It's the unprecedented effort indeed, as we try to see how we can win the fight against the pandemic. We acknowledge quite a lot of questions that are in the chat, and we'll try to reach out and have these answered and post them together with the session recording. It has been an interesting session indeed, and we look forward to seeing this rollout. As Trevor has mentioned, we cannot afford to relax. Speed is important. Quality assurance will be key. On your screen right now, as usual, are the codes that you want to be able to follow this session on the ASLM Academy. If you need any documentation of having attended this session, you can use that code that is on your screen and download your certificate. This recording will be available on our ASLM Academy website within a day or two. So probably early next week, that should be available if you want to look at it. We continue to bring these sessions to share information and the latest developments on what is happening regarding diagnostics in the pandemic. So watch out for the next session. We should be advertising early next week. Until we meet again, I would like to say good morning, good afternoon, and good evening. This is Anafi Mataka signing off. Thank you. Bye-bye.